Hello and welcome everyone to today's webinar, Sustaining Statewide Certified Community Behavioral Health Clinic Programs. My name is Logan Kelly. I'm a Senior Program Officer at the Center for Healthcare Strategies. Today's webinar is supported by the National Council for Mental Wellbeing. And before we get started, I'll quickly go over a few logistics. To eliminate background noise, all audio lines are being muted during today's event. There will be a moderated question and answer session today following the presentations. Today's event will be recorded and shared publicly on chcs.org. And at the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is really valuable to us, and we hope you will take a moment to do this. Next slide. So I will provide a brief introduction, and then shortly I'll turn it over to Dr. Joe Parks at the National Council for Mental Wellbeing to provide some more background information. Before that, I'll just, next slide, share some quick background about the Center for Healthcare Strategies. CHCS is a nonprofit that works with stakeholders nationally to strengthen healthcare services to ensure better and more equitable outcomes, particularly for children and adults served by Medicaid. This slide just shares a little bit more about the work that we do. We can go to the next slide. We are really excited today to spotlight the Certified Community Behavioral Health Clinic, or CCBHC model, and really explore how states can lay the groundwork for CCBHC sustainability. Soon we'll hear from Dr. Joe Parks, who will describe some key components of the CCBHC model and the current landscape for how states are implementing the model, both through federal Medicaid-funded demonstrations and independently. Next, I'll share findings from a just released brief on lessons from other Medicaid programs for CCBHC sustainability. After that, we'll hear from two state leaders of states, Missouri and Kansas, which are really at the forefront of innovative work with CCBHCs. And finally, we'll have a question and answer session where all of our speakers will answer questions submitted by audience members. And we know that there is a lot of interest from many different stakeholders who joined the webinar today. Those who work for state agencies are the primary audience for today's webinar, and we're featuring two state leaders today. If there are any clinics looking for technical assistance around the CCBHC model, the National Council for Mental Wellbeing has a training and technical assistance resource center that may be valuable to you, and we'll share a link shortly to that in the chat. Next slide. So you can submit a question online anytime by clicking the Q&A icon, which is at the bottom of your screen. And we really look forward to the opportunity to answer as many participant questions as possible. The next slide. And I'm so excited about the expertise and the perspectives that our speakers bring today. Valerie Hoon is the director for the Department of Mental Health in Missouri and brings extensive background in state government leadership. She will speak to Missouri's CCBHC approach, beginning with their participation in the federal Medicaid CCBHC demonstration. Director Sarah Fertig has served as the Kansas Medicaid Director since 2020 and previously served as the State Medicaid Inspector General. Director Fertig will speak to Kansas's independent statewide implementation of the CCBHC model. Dr. Joe Parks is the Medical Director for the National Council for Mental Wellbeing and a national expert in the CCBHC model and implementation. He's also a distinguished research professor of science at Missouri Institute of Mental Health with the University of Missouri St. Louis and practices outpatient psychiatry at a federally funded community health center. Next slide. So now I will turn it over to Dr. Parks with the National Council for Mental Wellbeing. Welcome, Dr. Parks.
Thank you, Logan, and thank you in particular for having me on to talk to this audience of state civil servants. And I'm thrilled because I've worked in the departments of mental health in Ohio, Illinois, and most recently Missouri. So it's great to be back here being able to present to my own. My job is to do level setting on the Certified Community Behavioral Health Center model in general broadly, before we do the deeper dive into how it was implemented and how it works in Missouri and Kansas. Next slide, please. So certified community behavioral health centers really stand on four pillars. They are a standard definition, the first standard definition we've had for a community mental health center since 1980. And it's hard to standardize, it's hard to improve things that aren't standardized. It's evidence-based care, assures that it's effective clinical treatment, and it rests upon the accountability of quality reporting and a prospective payment system that also includes a standardized cost report, and the payment is adequate to cover the CCBHC costs. So 4 pillars here. Next slide. So what goes into becoming a certified community behavioral health center? Well, there's 114 certification criteria that break out into several areas. You have an organizational authority, you have staffing standards, you have multiple standards for access to care. One of the big wins has been all states implementing have seen substantial increase in access. There's a defined scope of service that has to be comprehensive, has to include both mental illness and substance use disorder treatment. They're required to do care coordination, including care coordination of medical surgical conditions. And then they have standardized quality reporting on 24 different measures, not including the cost reporting. The payment is a cost-related Medicaid reimbursement rate for centers that are in either a statewide demonstration or whose state has implemented a state plan amendment or a waiver, or it can be time-limited grant funds, $1 million a year for up to 4 years, and that goes directly to individual organizations from SAMHSA. Next slide. So drilling in a little deeper, there are 2 kinds. The grant funded, they have a time-limited grant, and they can both get an initiation grant, the PDI, or a continuation grant. The clinics that have gotten statewide grants in the most recent include Indiana, Washington, Maine, and North Carolina. Now, the grantees self-assert to SAMHSA that they meet the grant requirements. They are not certified, rather they're self-attesting that they meet the grant requirements. And the grant funding is capped. It's a set amount of money, $1 million, to fill in and provide to the extent possible those things that aren't covered in their other usual state mechanisms, usually a fee-for-service system, and it's available for the duration of the grant. So the clinics bill all the other payers at the usual rate, and the grant supplements, but does not supplant the other payments. And they get just the normal federal match for CCBHC services, no enhanced match. Comparatively, the state certified grants, the state actually has a role in certification. They have to individually decide what clinics make the criteria and which ones don't. They get to exercise their own judgment, whether it's a demonstration, a state plan amendment, or a Medicaid waiver, a significant control lever there. The states could do a certification process to verify that, and they can put in recertification. It doesn't necessarily have to go on forever. The Medicaid PPS rate is cost related. It's calculated for each individual agency. The cost reports are reviewed by the state and approved by the state, another substantial way to keep accountability in the program, but also to make sure that the required services, which are comprehensive and substantial, are adequately funded to really be there and not be thinned out so much as to be ineffective. Clinics receive the Medicaid PPS, which is a bundled either daily or monthly rate inclusive of all service, so it's a bundled payment. Demonstration states get 4 years of enhanced FMAP. The state plan amendment and 1115 waiver states would get a normal FMAP. Go ahead, next slide. So a little more on the payment options. You can either choose to go with a daily rate, the PPS one client, one payment per day, in any day in which they receive at least one qualifying service. And the state gets to define what services qualify to trigger a payment. Many of the things the CCBHC does will not trigger a payment. Then there's also the other option, a monthly rate, one payment per client per month, for any month in which they receive at least a service. And this rate actually can be stratified. If you do the PPS 1, you have to have a single rate for everybody. The PPS 2 is stratified with higher rates, and you can design those groups depending on what your state wants to do. You could have a rate for children, a different rate for people with serious mental illness. You can stratify by the criteria that you choose in as many stratifications as you choose. Either can include, the PPS 1 may include a quality bonus payment. The PPS 2 must include a quality bonus payment. And these payments can either be made in as a wraparound payment by the state. Some states choose to have their managed care organizations pay their usual fee for service, and then they pay the difference as a secondary payer, or it can be paid directly through the managed care contracts as a established rate table going to a mandatory provider. In either case, the CCBHCs are required to submit annual cost reports. Next slide. So they are not business as usual. It really is a more comprehensive service and a higher bar for quality. They require greater scope of services than most clinics provided previously. Has to be full age range, comprehensive. It establishes standards and expectations for collaboration with police, hospital, primary care, a large number of entities in the community that are needed to serve the whole person needs of people with mental illness and substance use disorder. It requires improved integration across those different organizations. It supports service delivery outside of the clinic, in the community, using both regular clinicians and non-clinical staff to engage people at the right place and at the right time and at the best unit cost. You're not limited to only licensed professionals if you can get the service done well with an unlicensed professional. It standardizes quality reporting and aligns it nationally. And it introduces some risk into the provider pay via the encounter-based payment. They have to make it work out on average over time. But that also gives them flexibility to be more innovative, to do evidence-based treatments that may not have fee-for-service billing units available for them. It offers opportunity for provider organizations to participate in the financial model under the CCBHC. They can subcontract with designated organizations to do some of the work, and they can be part of the model in the community too. Next slide. We've been seeing a rapid growth of the program, starting out with 66 organizations in 2017. Now we're up to over 500. It actually at times gets difficult to keep count. Go ahead. Well, here's a map of the landscape implementation. You can see the orange states are the Medicaid demonstration states. The blue states are states that have legislation or have allocated funding for CCBHCs. The teal states have one or more organization or clinic that's gotten a SAMHSA grant. And the check marks are states that have a CCBHC, SPA, or 1115 waiver. And you can see a number of the demonstration states also have backup arrangements or expansion arrangements with a state plan amendment. And we're going to be hearing, and you can go forward without being part of the demonstration. So I think that ends my comments, and I think it's back to you now, Logan.
Excellent. Thank you so much, Joe. Now, actually, Joe, this last slide here, did you want to speak at all to this before we move on?
Thank you.
Sure.
Yeah, so there is going to be another round coming up in this year of more expansion grants. There will be 15 states that will be selected for the demonstration grants. They will receive $1 million for a year of funding in March. So watch for that announcement. 10 of these states will be added to the demonstration in July of 2024. So 10 more CCBHC states coming next year. Additional opportunities will come every 2 years after that. And of course, a state can implement the CCBHC by state plan amendment or waiver using your independent Medicaid authorities at any time that you have the arrangement negotiated through with CMS. That was the Kansas approach, and we'll hear about how they went about doing that. Now I think it's over to you, Logan.
Excellent. Thanks so much, Joe. So as Joe just illustrated the landscape going forward, I'll take a moment and look back and share a little bit about our research into what prior Medicaid programs with temporary enhanced federal funding can teach states and other stakeholders about strategies to sustain CCBHCs. Next slide. As Joe mentioned, the CCBHC demonstrations have time-limited enhanced FMAP, which is really designed to encourage and support state participation. And it also raises questions about how states can sustain the programs when that enhanced funding ends. To explore those questions, CHCS examined lessons from two prior initiatives. First, the Medicaid primary care fee bump that was part of the Affordable Care Act and required states to increase rates for primary care services to Medicare levels over a 2-year period. And approximately a third of states either partially or fully continued that fee bump. Next, we looked at Medicaid health homes, also part of the ACA, and which established state plan options for provider organizations to provide health home services for eligible Medicaid enrollees with chronic conditions and/or serious mental illness. About a third of states now operate health home programs, and CHCS interviewed current and former state Medicaid leaders across 9 different states to find out more about why these prior programs, kind of what their initiation and the decisions about whether or not they were sustained can teach us about CCBHC sustainability going forward. This report was just released today. There's a link here on the slide, and we'll share a link to that in the chat as well shortly. We can go to the next slide. And the paper has a lot of information about the nuanced perspectives of state leaders on whether and how their states initiated and either sustained or didn't sustain these programs. For today's webinar, we'll focus primarily on direct takeaways for CCBHC sustainability. On the right, you'll see an appendix to the report that we think will be quite valuable, and that shows a summary of state certified CCBHC activity, including relevant legislation and state plan amendments. And we hope that these resources can help to support other states to develop their own CCBHC sustainability strategies. Next slide. So the brief identified 4 core lessons related to sustaining CCBHCs. This first one focuses on aligning CCBHC implementation with state priorities. And this was really top of mind for Medicaid leaders that we interviewed when they were thinking about whether they chose to sustain or to end past initiatives. They recommended to plan and budget early on for when enhanced FMAP ends. And demonstrating that upfront state commitment will help first to spur provider interest in the program, and also second to secure funding once the enhanced FMAP ends. Second, there's opportunities to tailor how the CCBHC model is designed, such as through the certification process or through value-based payment performance incentives that can really address and align with state priorities. Some of the priorities that state officials have really indicated that CCBHCs are uniquely positioned to address include access to behavioral health in crisis, workforce shortages, health equity, and primary care integration. And states can leverage different resources to sustain CCBHCs, as Joe mentioned, including state plan amendments to cover CCBHC services under Medicaid, and enhanced match through the American Rescue Plan Act to fund CCBHC services and address crisis services. Next slide. So the second lesson focuses on the importance of early and frequent stakeholder engagement. We know that this is already a big part of statewide CCBHC approaches, and multi-stakeholder engagement is a requirement for the demonstration planning grants, but I'll underscore why it especially matters here. It can take a few years to see the impacts of CCBHC programs. And during that time, it's important to build the broad base of support needed to sustain a program in the long run, and educate stakeholders about emerging evidence as it develops, and then use their feedback to refine the program as needed. Second, the CCBHC model aims to achieve more integrated care, and that has to start with breaking down the silos between physical health, mental health, and substance use care at an administrative level. So in some states, CCBHC programs are led by behavioral health departments that are separate from Medicaid agencies. In these instances, it's just especially important to engage Medicaid officials in the design and implementation of CCBHC models so that it's aligned with Medicaid priorities. And there's also opportunities to collaborate with criminal justice and child serving agencies that serve populations that may especially benefit from CCBHCs. Next slide. The next lesson is to leverage data that can build the case for sustainability. CCBHC program requirements for quality metric collection in the demonstration are a strong starting point for evaluation, but states might want to explore additional cost and access and quality data to help really understand the impact. And for expenditure data, it's critical to broaden the frame of what CCBHC impact means and to assess spending both from inside and outside of Medicaid. So I'll just highlight two considerations here. First, when designing cost analyses, states should look at whether there are CCBHC services that can be included and brought into the PPS rate that previously were provided with 100% state funds. Some examples can include outreach and evaluation, population health management, care transition support, and others. And cost analyses can be designed to help states really see the impact of bringing those services over into the CCBHC model where there is federal match. Second, the cost impacts of the CCBHC program are known to shift over time, and states likely experience increased spending during the first few years after the program is launched. So it's important to analyze the budget impacts outside of Medicaid as well. And that includes state-only mental health and substance use services, criminal justice, human services that can really help to illustrate a more comprehensive picture about the overall impact of CCBHCs on state budgets. And Missouri has done a lot of work to create a shared CCBHC data platform to help the state gather the kinds of comprehensive data that's needed to do this kind of analysis, and we'll hear more about that shortly. Next slide. So our fourth and final lesson is to align CCBHC programs with state payment reform goals. And Medicaid leaders really underscored how important it is to connect CCBHCs with state VBP approaches. At a high level, some ways that states can pursue value-based payment, as Joe mentioned, include using quality bonus payments, and the PPS2 payment model with monthly clinic-specific rates is similar to capitated payments. And then there's also ways that states can customize the payment design, such as how and whether they recalculate rates, defining a billable encounter, and just establishing the role of managed care in administering those PPS rates. And this is an area where it's really helpful to learn from other states about how the CCBHC structure and requirements and areas for customization can be aligned with state payment and delivery system reform initiatives. And we'll hear more from Kansas and Missouri about this. And states may need to provide support to providers to take on greater risk, such as through infrastructure supports and technical assistance. And in the paper, I'll just share quickly that we highlight Oklahoma's PPS2 monthly rate. It has two tiers, one for the general population and one for individuals with high acute care utilization, which incentivizes CCBHCs to engage with individuals who may be hard to reach. And the model includes bonus payments as well as some downside risk if clinics don't reach those encounter goals. So it's an interesting illustration and state example of what it looks like to align CCBHC payment with some of their broader state VBP approaches. Next slide. So I'll just sum up some findings from this research. First, just that state leaders value whether programs and funding can be adapted to their own needs and policy contexts and want to see how new programs can address these broader state needs. While enhanced FMAP may spark stakeholder interest, it's really just one piece of the broader decision about sustainability. And there's a lot of other points of leverage related to sustainability that states can plan for. And the CCBHC model is well positioned to help states respond to pressing needs and pursue their long-term priorities. Next slide. So next, we are really fortunate to be joined by two state leaders who together represent both demonstration and independent implementation, and just each bring such great expertise and insight on how to design strategies to build and sustain CCBHC programs. So we'll first hear from Valerie Hune, the director for the Department of Mental Health in Missouri, and then I'll introduce Sarah Fertig, Kansas Medicaid director. But first, I will turn it over to Valerie. Welcome, Valerie.
Thank you, Logan, and thank you everybody for joining today. Missouri started down the CCBHO's path really before the national legislation passed in 2014. At that time, I was in the Missouri State Budget Office. I was the assistant budget director, And we had continually funded some general revenue only programs to address our needs in the mental health field with access to care, with crisis, complaints we were hearing from law enforcement and hospitals predominantly. And when the CCBHO model was presented at the national level, the department came to me, which now I'm the department at the time, and suggested that we go down this path. I will tell you, as at that time, state budgets were tight, so the thought of getting an enhanced FMAP was really exciting. But we also knew that the way it was presented to us, we were going to be able to collect high levels of data, and we would be able to tell not just the anecdotes we would hear from the hospitals or the sheriffs, but we would actually be able to tell if we were making a difference in the system. I'm going to talk a little bit more about that. When we started this, we had 15 CCBHOs in 201 locations across the state. Today, we have 21 CCBHOs, we call them CCBHOs, CCBHCs with 358 sites across the state. And we actually have talked about sustainability a couple times. So for those of you that have been in the demonstration as long as we have or are thinking about the demonstration, a couple of different times we were planning for the demonstration to go away and to go ahead and work with our General Assembly and our governor to get the funding to replace the enhanced FMAP put back into our budget. Fortunately, Congress, through some continuing resolutions and additional changes in language, have now extended that until September 30th of 2025. But that doesn't mean that we're planning for that sustainability by now. Missouri's actually been in this process. It will be through 4 governors before we actually have to replace our enhanced FMAP. So continually educating folks about that is really important. I will also tell you, none of this would have been possible without our partners from our community mental health centers who became CCBHCs. We have community mental health centers and substance use providers who opted not to become CCBHCs, recognizing the value of their service at that level. We also have a great Council for Behavioral Health in the state of Missouri who has been huge in allowing us to be able to collect the information we need to collect at the state agency to maintain this service in the future. So a couple of things I also wanted to point out. Missouri is still operating in the demonstration, but part of sustainability, if you're a demonstration state, is getting your state plan amendment ready. So make sure you're working on that or are thinking about that all through your demonstration process. We do have a state plan amendment approved here in Missouri. However, we are not currently operating under that. We're still operating under the existing demonstration. Also, stakeholder engagement early on, and that's from our partners and other state agencies, as well as our community providers and our outside stakeholders. So our Medicaid agency, our Department of Health and Senior Services in the state of Missouri, Missouri Hospital Association, the sheriffs in the state, and of course our Behavioral Health Council were all key in really building that stakeholder support at the ground level. And I'll just give you an example. In FY20, which would have been in 2019, we actually were going to need to replace about $24 million in our budget general fund to replace that enhanced FMAP. And what we started talking to legislators, and our stakeholders had already beat us to the punch. The hospitals had already gone. In fact, we were in a meeting with the Senate Budget Chairman, and the hospital and his district had already come to him and said, whatever you do, make sure you fund this. And what we were able to do then was go on the backside with all the data that we had collected and explain to him why what they were saying was important. And so I think one of the big key factors that I want to point out there, and we collect this data, we built these data because it's part of our payment mechanism. We are a we have value-based payments that are tied to these CCBHC services. And our legislature and our governor really, really like to know that we're paying for value as well. But because we're building that as part of our payment structure, collecting the data is very important, but also building that data collection into the PPS rate, into our rate is possible. And that really has helped us a lot. So it's really not us, the state, collecting the data. It's the providers who are using one single source to collect all of their data. They all are a part of that single data collection process. And then we're able to utilize that data to make payments and to tell our story. One of my favorite parts of the story to tell is that one of our value-based payments is around hospital visiting, follow-up visits after somebody's been into a hospital by our CCBHCs. And what we know is that we have not only decreased the number of people accessing the emergency rooms, and we have data. We've reduced hospitalizations and emergency room visits. We have data that supports that, but our data also supports, we've decreased the cost of people whenever they actually go into the hospital. So two things that we've been able to do, and that accounts to about $15.4 million worth of savings. So I know Logan touched on, make sure you're accounting for your savings in these other areas. That is very, very true, because we have a lot of those savings. It's harder for us as a state in Missouri to account for our law enforcement side of savings, because that's all done at the local level, but we do share that data locally, and then we allow our sheriffs as stakeholders and our law enforcement as stakeholders to come in and talk more about that. But I just want to make sure, just leaving you with a couple of things real quick. Make sure you're using data. It is the key, and you're using that with stories for your decision makers. Make sure you include that data collection as part of your payment process, because that's really, really important. You can't build a value-based payment without data, and it can be a part of that process. And also make sure you show how it saves money in other places. And then I did want to point out one last thing, and I'll move on. The last thing I wanted to point out is, because we've had this CCBHC system in the state of Missouri, our 988 launch and our data collection on our 988 launch has been really, really spectacular. We're able to show a lot of information quickly to our legislature, because that's still something we're continuing to get funding for. And then the second thing is when your partner agencies need help. So a good example for us was our children's division in the state of Missouri. They needed to launch an independent assessment. They're our foster, they do child welfare. They needed to launch that independent assessment. It's part of the Family First Act, and they actually ended up working with our CCBHCs in Missouri to be those independent assessors, and we're using our data system that already existed to help collect data in that method. So it's what it's done for us in the past. It's increased our access. We've been able to achieve savings, and what it's doing for us in the future. So that's just a real quick sustainability Missouri style, and back to you, Logan.
Excellent. Thank you so much, Valerie. And I'll remind everyone that if you have questions, please feel free to enter those using the Q&A feature at the bottom of Zoom. And now I will introduce Sarah Fertig, who will speak to an overview and sustainability of CCBHCs in Kansas. Welcome, Sarah.
Thank you, Logan. And good afternoon, everybody. My name is Sarah Fertig. I'm the State Medicaid Director for Kansas. So Kansas's path towards CCBHCs is much briefer than Missouri's, although we have looked to Missouri for kind of a model on how to proceed here. So the discussion in Kansas on CCBHCs really began when that first round of SAMHSA grants was made available. At that time, the state was still working to stabilize its move towards mandatory managed care for all, virtually all Medicaid populations. And so the state really didn't have the bandwidth at that time to apply for one of those planning grants. And so we kind of let that opportunity pass us by. However, it became evident in the ensuing years that there are a lot of gaps in behavioral health in Kansas. So there were a number of legislative committees that met and identified specific areas that the state needed to improve upon. We weren't doing a whole lot in terms of integrated care. There was an increasing need for crisis services, and we were experiencing issues with access where, the demand simply outpaced the supply for behavioral health services. And so some of our CMHCs in the meantime stepped up. They applied for some of the SAMHSA grants to do demonstrations. And so they were already starting to do the work before the state kind of came on board with that. And all of this kind of came to a head in 2021 when we realized that, we have some CMHCs who are facing a drop off in grant funding to operate their CCBHCs starting in May of 2022. What are we going to do with that? And the answer was legislation that required the state to have a CCBHC program up and running by March 1st of 2022. So that gave the state, the agencies about 11 months to launch the entire program, which is a very, very short period of time. So what we did to help expedite, one thing that was really critical for us on the launch was, number one, getting our agency ducks in a row. So in Kansas, my agency, the Kansas Department of Health and Environment, is the single state agency for Medicaid, but we also work very, very closely with the Kansas Department for Aging and Disability Services. They are the lead behavioral health agency in Kansas, and they also administer all of our HCBS waivers. So we already partner with them on the Medicaid side. About a month after the bill passed, setting a due date for us to start with CCBHCs, we started setting up weekly meetings. So we would have, at first it started out with a single weekly meeting with the CMHCs, who were the first target group for CCBHCs. So the two agencies and the CMHCs would meet weekly. Later, we added a second meeting. So we would meet with National Council and the CMHCs 1 day a week. And then we would also meet with the state's consultant who is helping us launch the project on another day. And so twice a week, we would have hour-long meetings, and all we talked about was CCBHC launch. And I really think that frequent contact allowed us to troubleshoot issues when they popped up really quickly, because it is a complicated thing to lift off the ground. And candidly, Kansas still has not debugged the entire program. Here we are, we launched in May of 2022, and there are still issues that we are ironing out because it is pretty complicated, especially when you're talking about overlaps with HCBS, any health homes, all sorts of that stuff. So what really helped us was just very close collaboration with the entities that were planning on transitioning to the CCBHC model, so we can make sure they knew how to submit cost reports, which is something that these providers had never done before. We paid for and arranged for training for those entities. KDADS, our sister agency, set up a technical assistance platform to help kind of usher those facilities that were applying for CCBHC certification, explaining to them, what the requirements are and what certification was going to look like. So it required a lot of collaboration with the entities that were going to become CCBHCs, but also among the agencies ourselves. So because we had such a short launch ramp to get these off the ground, we did make some decisions early on. So for PPS rates, we decided that we were going to walk first and then run. And we went with the PPS 1 option, which is a daily PPS rate. And we're not doing any add-on payments or wraparound or anything like that. It's, let's just get this off the ground first. We are also phasing in implementation of CCBHCs in Kansas. We launched 9 of them by July of 2022. We're on track to launch another 9 by July of 2023. And then we're looking to add 8 more in the year after that. So kind of phased in over 3 years. And that has really helped the centers understand what the shift is, because this is a sea change for a lot of them. But it's also helped the state kind of manage the workload there. So what's in terms of the future for CCBHCs in our state, we're going to continue the launch. We still have a lot of work to do in that regard. We're also looking onto the data piece. As Valerie mentioned, Missouri has a really slick data collection component for their CCBHC system that allows them to document and provide data to support the state's investment in these services. And so that's something that Kansas is exploring as well. How do we be able to, report back to lawmakers and stakeholders to demonstrate that this is working? So that's something that we're working on now. And I also anticipate that we're going to increase our collaboration with some other providers and possibly at some point even expand the types of providers who can become CCBHCs. Once we see the model really take hold in Kansas and working, I imagine that we might have other providers who want to reach out and become certified. So a lot of work left to do, but it would not have been possible without really, really close collaboration with the CMHCs in Kansas and also with our sister agency, KDADS. That was imperative. And so for those of you who are looking into that, I would suggest having those meetings early and often. And I would also suggest bringing in expert help. We had the benefit of a consultant. National Council also assisted there. There's really not too much help that you can get in this regard to help kind of chase down answers to some of the details that pop up. So that's a high level overview of the Kansas story. And Logan, I will turn the microphone back to you.
Excellent. Thank you so much, Sarah. I'll invite all of the speakers now to come on screen and we'll start to answer some of the great questions that have been coming in. If you haven't had a chance to ask your question yet, please enter it now and we'll try to answer as many as we can. So first, we got a question really asking what's the kind of infrastructure and relationships have been that have been most key to help sustain the CCBHC model. So Valerie, I'll start with you. We received a number of questions about Missouri's data collection process. Can you just kind of speak to how you've supported enhanced data collection and sharing for CCBHC implementation? And there's also a question about how that was kind of data collection was built into the rate setting process.
Yeah, so first of all, I'll do the last one first, because that's really a lot easier for me. That's just part of your administrative function of your CCBHC. So you build that data collection onto the administrative side. And, you know, I've done a lot of work on learning how to launch value-based payments on the developmental disability side. We've been in a lot of national collaborations on that. And you have got to get the data collection right up front. If you don't have data collection right up front, you will never be able to implement a value-based payment. You'll constantly be in a fight with your providers over what's correct and what's not correct. Second, you'll never be able to mature that payment. And that's really where we're next step in Missouri is maturing that payment. So once all of your providers start to get the payment, you realize maybe we need to take this a step further and we need to demand more quality out of our providers. But to talk also just a little bit about the why it's how we did the data enhancement, why that's important. I think that, and I have to break down because I know I was going to need to answer this. I think the key is what we ended up doing actually was making it easier for our other providers. So before our providers were supporting multiple EHRs and then having to do all of these things where you were becoming interoperable with another system. Now all of that's built in. It's a single source. It's a single place for information. And I think that's also been really, really important and why I think states should take a look into that further. So those are just a couple of the key things I think were important.
Excellent. Thank you so much. And Sarah, can you speak to kind of what infrastructure and relationships in Kansas have helped you to launch the model even without the enhanced match?
Sure. So that's a really good question, Logan. And obviously without the enhanced match, we were looking at a bigger lift from the state general fund side. And what really helped us there was that our kind of key partners in the legislature already knew that we had to do something big to turn behavioral health around in Kansas. And so that case had already been made through a number of legislative studies and from hearing from our providers that really, you know, not to pick on one of our neighbor states, but we were losing providers to Oklahoma to our south. No, not Missouri, Valerie, I'm not going to pick on you. So we were losing providers to our neighbor to the south because they were able to pay licensed providers more. And so our behavioral health system, which was already strained, was getting worse, you know, by the month as more and more providers went to better paying states. And so we were kind of at a crisis point, and really having the legislature understand that and also understand that this is not going to be cheap. Number one, I mean, it was tens of millions of dollars. It's not going to be cheap. And we're going to have to sustain it. This is not a one-time funding. This is going to be something that is in caseloads year after year after year. It is an ongoing investment, but it's one that we need to make. And we were able to make that case with assistance from some key legislators in Kansas.
Excellent. Thank you so much. So we're getting a lot of different questions about workforce. And so I'll ask everyone, can you share how the CCBHC payment and fee structure can be designed to improve access to care, especially given all of the challenges that states are experiencing related to their mental health and substance use care workforces?
I'll start off if I may. Oh, go ahead then. Go ahead, Sarah. Val, go ahead.
Well, I was just going to talk specifically, I think it's broadened who we can bring into our workforce and actually get reimbursement for. Peer specialist is probably the category I think is the most exciting category in terms of the workforce. So please recognize Missouri is a huge workforce crisis, just like every other state. We don't have enough psychiatrists, we don't have enough psychologists, we don't have enough social workers. So you've got to be able to be as strong as you can in accessing every possible person that can be supportive in your workforce. And so in a fee-for-service model, we weren't able to pay for peer specialists, but in this CCBHC model, we are able to pay for peer specialists. And just to give you an idea, from 2017 to 2021, we increased the number of peer specialists in Missouri from 36 to 111. You gotta love data, right? I mean, it's right here. So, which we collect, by the way, too. But we've also been able to increase a lot of other categories as well. Our APRNs and our physician assistants, both of those have also gone up quite a bit. So it really allows us to spread the workforce, I think. And now I'll go to Joe.
Yeah, you can also cover the costs of things like ancillary staff that make your rare staff more effective. Things like scribes for the prescribers or people to help room the patients that are getting a medication service. You also can pay for services that make you more efficient, like the consulting and coaching it takes to implement same-day access or just-in-time prescribing. So you can get more efficiencies by being able to cover the costs of that training and consultation.
And I would add, it also frees up the providers to do some salary adjustments for their staff to retain them better. And all of that will flow into the PPS rate and eventually get reimbursed. So it does allow providers to have some consistency and some guarantee that Medicaid will continue to support them as they better, support their staff and try and keep them on.
And of course, retaining people over a longer time is a major efficiency move, because somebody that's been with you 3 to 5 years is going to be able to treat more people than somebody that's only been there 6 months or 12 months and doesn't know the system, the rope, and isn't in their stride and their rhythm yet.
Great, thanks so much. And then we received a question asking how states have managed licensure, compliance, and monitoring. And can you just describe what state agency is responsible for those functions and kind of what it took in terms of staffing and scaling up the infrastructure for those processes?
So in Missouri, we were already licensing our CMHCs. Now it's different, the CCBHO model is different, but we really had that structure in place already. So it was just adjusting that structure.
So in Kansas, we had to kind of build that from scratch, and it was not my agency that is responsible for the licensure and monitoring and all of that. It's our Kansas Department for Aging and Disability Services, and they brought on quite a few staff to support the CCBHC model. That was all part of our fiscal note for the legislation, so they are staffed up so that they can do that monitoring.
But just as Val was able in Missouri to support a statewide data infrastructure based on administrative charges to the CCBHCs that are in the PPS, you could potentially also support a certification function that you would want to make external with some independent entity of your choosing, but you could push that out and do it as a local state-based solution. Also, we understand that a couple of the accreditation agencies have CCBHC accreditation/certification offerings in the works that we expect to see in the coming year, which would be allow a state for some level of deeming if they wanted to use a totally outside entity coming up in the future year.
So we've also received a lot of questions related to how CCBHCs fit into managed care arrangements. So can you just speak briefly to how that works in your state?
I can start that one, Logan. So Kansas is a 95% managed care state. And for us, it was pretty simple. We created a new provider type, and the way our managed care contracts work, our MCOs have to pay according to state policy. So we wrote a policy and said, here are our CCBHCs, here's the rate you pay them with PPS. And that's it, they pay the PPS rate. You know, we do allow our MCOs to engage in value-based contracting with providers if they're interested in that. So that's something that they can pursue. They're free to pursue that with CCBHCs, but we have the floor PPS rate that they have to pay under our policy.
Missouri's got both managed care and non-managed care, and it's like Sarah said, in Kansas, it's all managed through the contract. So that's not a scary thing.
That said, a number of other states have decided to allow their managed care companies to continue to pay fee-for-service for the usual menu of services that they would pay any provider. They then have the CCBHC bill the net of the remaining payment back after they've received all payment from the MCOs. And states are set up to handle this because that's what a number do for dual eligibles anyway. So it's just adding one more payment type to a net payment operation that you already have in place in every state that I know of.
And then just to understand the kind of what it takes on a state side, there's a question about how many FTEs and what kind of staff are working on CCBHC implementation in Kansas at the state level. So Sarah, I'm curious to hear your response on that.
It's not my agency. I don't have the specific number on top. I know that we've got a couple folks from that agency on this call. If they feel like dropping something in the chat, they're welcome to clarify that. But yes, I'm afraid I don't know that number off the top of my head.
Sure, appreciate that. And if someone wants to enter that into the Q&A, we can share that with all. So then we got an interesting question when trying to understand how to allocate their resources and sitting in conversations about CCBHCs, behavioral health integration into primary care, and other models, and describing kind of being overwhelmed by trying to figure out what would be most effective for their communities. What elements helped you choose the best model to move forward with?
I think for Missouri, it really is important that we've changed the payment structure. So we've gone from that fee for, and remember, I came from this from a budget standpoint, then a Medicaid standpoint. So I'm thinking of it as really bureaucratically when I say this, but we just knowing that fee for service really is one, as a state, we were not keeping our fee for service rates up at all. So that was totally, we knew we were creating access issues because we couldn't keep those rates up. But also just, providers were just incentivized just to bill for hours and not to do anything for quality of services, not to do anything for expanding services, because really we created an environment where they could just barely get by. We were cutting provider rates more than we were ever increasing provider rates. We were not anywhere near a Medicare type of provider rate or any other private type of provider rate. So for Missouri, it was really, how do we make sure we can kind of build in a provider reimbursement structure that makes sense, that shows outcomes, that we can pay for value, and then at the end of the day, it isn't strangling our providers, because that's what we were really doing. So I do think that payment structure, that the way you pay for the service is really, really the big reason. And I know people are worried about, they're going to go crazy on their cost reports. You audit those cost reports, or think that you've got all those safeguards built in. If they're not meeting their benchmarks, they don't get their value-based payment, and their cost report's probably going to go down because they're not investing the money into the services. So that was really important.
And I just want to say that in all the states that were the original implementers in the first state demonstration states, we have not seen the PPS rates go runaway, increasing year over year. There was an initial reapproximation when they actually covered the cost of service, and after that, the increases have been close to the cost of general medical inflation. We've not seen one case yet of a runaway provider group.
So in Kansas, really the driving forces are a lot like what Missouri is reporting as well, where we have not kept up with fee-for-service rates. We were incentivizing a maximum number of services to be billed rather than quality of care. And so what we needed was really a comprehensive overhaul that would put the emphasis on, timely care, prevention, quality of care, but also make sure that the providers had some baseline expectation of payment, make sure that their financial needs were taken care of. So that can kind of free them up to do the kind of work that we really want them to do. So really that was basically everything that Valerie said was also the case in Kansas as well.
The other halo effect we've seen of the model is by requiring a standard cost report in this data-driven way of managing your business. These centers have all become much better, not just clinically, they become better business managers. They understand their business, they understand their finances, and it really has upped their game even beyond the payment model itself. It made them get smart.
Thank you all so much. So I think we have time for one more lightning round, maybe 15-second answers each of what advice you would give other states that are now beginning CCBHC planning.
Mine would be start early, expect to troubleshoot all sorts of issues, and bring in experts to help you out.
Mine would be trust and be transparent. Get all the parties at the table. Don't figure it out by yourself. Have Medicaid there, have mental health there, and have the providers. Get some good opinion leaders you trust, and have them in the room with you from day one. They'll help. You'll keep each other from making mistakes.
I'm going to say all that plus keep data as a key part of the development of your system, because if you forget that part, all those things on the backside that I talk about that are super fun to do right now, like value-based payments, those go away. So just make sure you keep data as a lens on the conversation.
This is great wisdom. I know that we received more questions that we unfortunately weren't able to answer today, including some on Missouri's data system. I'll note that we do spotlight that in the paper that just came out today. And if you have any other questions, feel free to follow up. I would just like to thank the participants for all of these wonderful questions. We really appreciated the opportunity to have this conversation with you all, and to thank our wonderful presenters for sharing such insight, and thank the National Council for Mental Wellbeing for supporting this webinar. We'll be publishing a recording along with the slides within the next few days at chcs.org. And finally, we would really appreciate if you can fill out the evaluation survey that will show up on your screen when the webinar ends. We really appreciate your feedback. So again, thanks so much to our presenters for sharing such great insights and experience with us today, the National Council for Mental Wellbeing, and everyone who joined us. Thanks again and have a great day.
And thank you, CCHS, for being a great, gracious host.
Of course. Thanks, everyone.